Welcome for another episode, 20-minute clinic. We're back again. Myself, Dr. Amit Paik, and I'm really grateful, actually, really interested in this podcast to discuss something actually remains a bit of an urban myth, a bit of a mystery. Early in my journey as a GP, and actually learnt a huge amount from hearing more about the service and how it interacts with patients. So specifically, we're talking about the North Cumbria Persistent Physical Symptom Clinic. And I'm joined really by a couple of figures from that team. Ingrid and Lucy, do you want to just introduce yourself?
So my name's Ingrid Wilkins. I'm one of the anaesthetic consultants at Carlisle, and I work with the North Cumbria Complex Pain Service in some of the clinics. I do one of my clinics with Lucy.
And my name's Lucy. I'm one of the psychological therapists that works for the Persistent Physical Symptom Service in Cumbria. And as part of that role, I also work into the North Cumbria Complex Pain team and help support the MDT and the Medicines Optimisation Clinic.
Fantastic. Thank you so much for coming, guys. It's really good of you to come along. So pain management, I think we do what we can to look after patients, but increasingly my journey as a general practitioner, and I think I hear this from a lot of my colleagues as well, pain management is almost a double-edged sword, it feels. Acutely, yes, very much a role for it, but I struggle increasingly with some of the medicine and some of the psychology around pain management, sort of like that chronic pain patient group.
Well, I've got involved as an anaesthetist. We tend to run the acute pain service in the hospital, so that's how I got involved in it. And then we don't have any chronic pain consultants in Cumbria at the moment, so we were a bit concerned about you guys referring in patients wanting to see a chronic pain consultant, and we didn't have a medical input into that. So we set up the MDT with psychology, physios and 2 doctors. We've now got a virtual chronic pain consultant who comes and joins us for our MDT weekly, and we can then triage all of the referrals quite efficiently with all of the right people in the room deciding which pathway we go down. So I've come into it sort of accidentally, and I have also learned quite a lot over the last few years, and increasingly understand that I have got not all that much to offer, and actually it's all down to Lucy and her team.
Lucy, I really would love to hear. I mean, you're kind of shaking your head over there, but I think there is a huge amount to this. Increasingly, pain is not just the physical elements; there's a huge amount of psychology, and I would go as far as saying kind of almost societal as well. What are your thoughts with all that?
Yeah. Pain absolutely generates emotions for all of us. If, right from if you've cut your hand to if you've sprained your ankle to living with persistent pain, there is an emotion attached to that. It might be shame because you did something silly and injured yourself, which has then caused that pain, and that pain is a reminder. But it might be the frustration and the low mood that comes around from having very limited function as a result of living with persistent pain day in, day out, and the impact that has not just on you personally, but on your social and family networks. So I think there's a huge element of psychological awareness that goes with kind of understanding pain.
Yeah, there's always so many layers to this, isn't there, almost, really? I really want to deep dive into that because that sounds incredibly interesting, really fascinating for a lot of our listeners, really. But Ingrid, I want to just pick up on services. So if we, for example, had a new clinical colleague in Cumbria, for example, and suddenly they face themselves with a patient with post-operative, still significant levels of opioid being prescribed to manage what was going from an acute to a chronic pain scenario, what are the things available from a clinical point of view to be able to support this?
So the first thing, obviously, is, and we're trying to work on this in the hospital, is about setting expectations for our patients, and so that we have started introducing the idea of stop dates for opioids in the same way that 20, 30 years ago we suddenly went, oh, people have been on antibiotics for ages and now they've got weird flora in their body. How could this happen? Maybe we should stop dates on antibiotics. So we're trying to do the same thing really with opioids and try and set the expectation that you'll have some acute pain after your surgery and we'll manage it with these painkillers for a few days, and then we'll expect you to not be taking them forever. You'll start to maybe taking them, instead of taking them 4 times a day, we'll go down to maybe twice a day, and then maybe you just take it at bedtime so you get a bit better sleep, or you take it before your physio, or if you're having a bad day and the expectation is that you stop taking your painkillers as your body heals. And so I think there's still quite a lot of work that we have to do in hospital making that statement. And I guess in the GP, when the patients come back after their operation, well, I need more codeine because it's run out. Well, do you need more codeine? Let's talk about how you're using your codeine and how that's helping you and what side effects the codeine is giving you. Oh, you're constipated. Gosh, that's directly related to the amount of codeine you're taking and is also making your life miserable. And so it's about questioning why are they on it and then starting to then decide that they maybe shouldn't be on it anymore.
Yeah, and I can think of sort of several scenarios, goodness me, that I've got in mind. And anyone listening to this will probably in that situation again, when they've had patients rock up asking for, or even over the phone, asking for a repeat or a reissue of a complex opioid beyond even codeine, for example, sometimes.
Yeah, so I mean, there's a difference, isn't there, between sort of immediate post-op. It's slightly easier to explain to the patient, well, no, as your body heals, you'll need less of the drug and the drug comes with side effects. For the patients, the legacy patients, I guess, of whom there are very many that have been started on morphine 20 years ago, then that's a whole different issue. And I think that's probably where we come in. And so one of the pathways that we run is the Medicines Optimisation Clinic. I run one in North Cumbria and my colleague, Dr. Slaymaker, runs one in West Cumbria. We don't have very many slots, so each month there are 8 slots across Cumbria. This isn't a sort of, daily clinic that we run. So we try to really pick the patients that we think are on a huge doses of drugs. But there's always complexity, isn't there, in that we think we can help with a joint appointment with a psychologist and an anaesthetist and a pain nurse, that we can explore some of the issues around how they've ended up on all of those drugs and whether we can actually improve their life by changing some of those drugs. And usually that involves a reduction. In
some ways, I really appreciate the service you offer because the complexity of these patients are significant. And we've touched upon the psychology element of it, but I mean, a lot of these patients will say to me, the pain is real, and you can't argue with them at all.
So the pain is real, but the answer is not painkillers, and the answer is not more morphine. If you're already taking 240 milligrams of morphine each day, and you're taking a maximum dose of gabapentin, and you're also on some other things, and you've still got pain, then the painkillers aren't working. That doesn't mean that you haven't got pain. It just means there are other ways that we need to help you address the pain, and that obviously is a much easier conversation to have during an hour with a psychologist and a hospital doctor, because the patients find that is different from a GP, and we have the luxury of 1 hour appointments, but it takes that long to go through all of the complexities and try and unpick it and to try and introduce the idea that actually more morphine is not the answer.
Yeah. And I'd shout out for our ACP GP colleagues who tried to squeeze this in 15 minutes.
I think the feedback from patients is largely that in spite of the best efforts, they feel not listened to or not heard or not understood. And that is due to time constraints and appointments. So I think it's a real privilege to be able to offer patients an hour.
Yeah, I mean, I can't think of a scenario when in primary care that's going to ever be doable. And I suppose this is some of the negatives of the system that we're in, really. I mean, some of that we can influence, some of that is system level. That's very, very difficult to kind of move. That's really interesting to know the time to be able to talk through, unpick some of the background around this from a medical, from a clinical angle. The psychological bit I'm fascinated on. I kind of feel from my own angle is that almost there's a patient expectation from Western medicine. A tablet will fix this. They will come in asking for an antibiotic. Yeah. They'll be issued with a tablet or a capsule, and then 7 days later, you like to think they've got better. That's the expectation.
In this day and age, I should be able to have a tablet to make this better.
Yeah.
I can't tell you how many times I've been told that.
Yeah, I've regularly. Absolutely, yeah. What are the challenges from a psychological angle there, Lucy?
So, I guess we get lots of patients in the clinic saying, why is there a psychologist in the room? I'm here to talk about my medicine, and there isn't a mental health component to my pain. I think that's one of the biggest issues. But I think when we're working with these really complex patients, if we work in silos, and if it was just Ingrid purely looking at someone's kind of pain prescriptions, we would be missing the bigger picture. And we really try and work in biopsychosocial kind of ways to really understand the difficulties and the challenges that people live with and face day to day. And pain actually just becomes a small component of that, because it has that ripple effect where it impacts relationships, it impacts people's ability to work, it impacts their mental health. It literally filters into every other area of their life. And if we just pick one small thing, then we're doing a disservice to those patients. So really it's about thinking, how else can we support you to manage your pain? Medication absolutely has a role, and you started off by saying, what do I do if somebody's got post-operative pain? Medication has a role in supporting rehabilitation, but beyond that it then becomes quite limited. But then it's thinking about what else can we do to support somebody live well in spite of their pain. And there's a whole host of things, not just psychological. The Persistent Physical Symptoms Service has highly specialised physiotherapists and occupational therapists and living well coaches to help support people to live well with their, it might be pain, it might be fatigue, it might be a whole host of other symptoms, way too many to mention. It'll take 20 minutes just to do that.
It's so nice to see that there is a true MDT approach to this.
Yeah.
It's not a unilateral approach accordingly. But what is the response from patients when they rock up? Once I refer a patient to you, for example, how long does it take for a patient almost to go from that Western style approach of, I'm looking for a tablet, have you got any more tablets, through to actually recognition of, this is something beyond a capsule here that I need to be thinking about?
Well, I think everyone's a little bit different. There is a sort of school of thought that we go with that every contact counts. Yeah. So it takes 7 on average, 7 contacts of, gosh, I wonder if the morphine's helping you. So you can do that in 15 minutes, you can do that in 10 minutes. I'm not sure that the morphine's helping you here, but we'll carry on for a bit. I'm really beginning to think the morphine's not helping you at your next appointment. I'm going to refer you to someone else. Oh, constipation is really a problem, 3rd appointment. Gosh, that really is a side effect of the morphine. I wonder if it's the morphine that's making you constipated. 4th point. And so the sort of drip approach that has hopefully been happening before they actually get to us. And then we've got the luxury of an hour and to really, really go into it. And so some people, if they've never heard that message before, we've got an hour to really explore it, really talk about it. We quite often give written information about the side effects, long-term side effects of opiates that a lot of people aren't aware of. And then sometimes we then need primary care to then take over that conversation and continue with that along. So it is, it's not one appointment and it's all sorted.
I can imagine it's several contact. I love that, the 7 contact point. Because even that's something arguably we could probably take on in clinics. We've got relationships with a lot of these patients that we can gently nudge down that route.
And so if every time they come in they're getting a consistent message, gosh, I'm really not sure that all of these drugs are helping you, beginning to think that some of the problems you're having are actually side effects of the drugs that we're giving you to try and help you. And again, it's about the language that we use, isn't it, around that? Not, you must stop taking this drug, you've brought this on yourself. That's not a helpful message. But we've been trying to treat your pain, and I think we've inadvertently now made you worse by making you constipated and tired all the time and actually reducing your sleep quality. And we all know that sleep is very important. Even my mother, who doesn't have a medical degree, knows that sleep is the best medicine.
Well, I think this is it, isn't it? This is it. So, I think that consistency, the gentle signposting and flagging of those difficulties associated. But it's not simple, is it? I think we all know that. So we won't. I will not offend anyone in primary care by sugarcoating this.
No, it's not. It is a team game, and it would be lovely if we had the luxury of being able to see these patients 7 times ourselves, and then also following them up through their reduction journey and, following them up on a sort of monthly basis. But we absolutely don't have that ability. So really that's sort of how we need to interact with primary care. And certainly we've got some patients who are on reduction programs, and we've got to know some of the pharmacists quite well, and there's a couple of them that will just email me directly now
Oh wow. Okay. Well, that's nice, isn't it?
We've come to a roadblock. What do you suggest? And then we can sort of tailor it, and it's quite efficient. And so, from your point of view, using the advice and guidance system for that is quite helpful. You've seen this patient in clinic. We've hit an issue. Any suggestions? And then we can answer that quite quickly. It doesn't take up a whole referral, so you get your answer a bit quicker, and then you're getting more of a direct interaction, hopefully.
Yeah, which I think is really important about that primary secondary care interface that we always talked about how many times over this podcast. But I think it's really nice to know that there is that kind of ongoing openness, ability to go and seek advice accordingly. Any additional, so I'm just thinking in my mind, a roadmap of being able to see patients in the hour-long clinic, formulate a plan, seek some support from primary care to continue that going. Is there anything else you feel as though that may well be helpful for that primary care input later on down the line?
So I think so we try to write a really detailed letter covering all of the things that we've talked about and put a tapering plan in if that's appropriate. Yeah. Sometimes they're not quite at that stage yet, so we'll make a suggestion that a tapering plan, you could start tapering once these other things have started. Sometimes we'll put an actual plan in place and we try and copy that to the pharmacists so that they can do that. So I think it's an awareness that if they've seen us in our clinic, there might be some slightly complicated and possibly, for your point of view, slightly irritating changes in prescribing on a fortnightly basis in order to try and get them down their journey. Okay. Because obviously you can't just stop.
No, of course not. And I think this is a team effort. I openly recognise that this is something that you can't unilaterally do with patients for a good outcome. I think this is almost a degree of team working and working with patients, which, if I'm honest with you, one of the assets of primary care is that relationship with patients that we can try and formulate and foster. So
our virtual chronic pain consultant always says, it is better to succeed slowly than to fail fast. And which I thought was him just being a bit flippant, but actually he's absolutely right.
That's a soundbite.
And actually the reductions that we've done super slowly are the ones that have been the most successful. Well, so you need patience. That doesn't come naturally.
Well, this is it, isn't it? Really, success stories. I'm really keen to pick out some of these. Are there any that keeping confidentiality, for this podcast. But are there any ones that are key, really standout ones? You think, wow, you know what? We've taken somebody from a real difficult place, and we've seen some successes with them.
I think it's quite challenging, and the reason for that is because of the constraints of the clinic. Where possible, we only ever see patients once, and then we send them back to primary care and we let you do all the good work and take all the credit. And so it's the success stories we never hear from again. But we've met some amazing people.
Yeah, we've had one or two people that we've sort of set off on a reduction journey and then have come back into the hospital as inpatients, and then I've seen them and they're on much less, which is very reassuring. And some people who've come back and said, well, my pain isn't really better, and they've managed to get themselves another appointment and their pain isn't any better, but their life is better. Wow. And sometimes, because they've come off all of the tramadol and they've halved or stopped their gabapentin or pregabalin, and actually their issues are still the same. Their pain often, although that's the reason they've come to the clinic, is not what they spend most of their time talking about. They're talking about their worries and they're not sleeping well because they're anxious about this, that and the other. But the particular man I'm thinking of was very chirpy and much more awake, and he wasn't on all of these drugs. And so I'm not sure how successful he thought it was, but I thought that was definitely a success.
Fantastic. Okay, look, I mean, we are doing good collectively in this sort of sphere of work. For our primary care colleagues out there, is there any particular asks, wishes, wants that you're open for them? Anything particular that you'd love to pass a message on to them, that you're keen to support these clinics?
Yeah, so we're moving. I'm sure you're probably all aware of the recent government guideline that modified release opioids are no longer suggested for chronic pain. They're also not suggested for acute pain, so they've come out all of our acute pain guidelines as well. And so really there's no place for modified release opioids other than in cancer pathways.
That's fascinating in itself. I did remember hearing something, but go on, just give us 30 seconds of the context of that.
If you use the same dose of immediate release morphine, and so we like Actimorph because it doesn't contain sugar and alcohol. It makes it slightly less moreish. Then you can treat the pain when it's acute. So if you are having a bad day, then you can take 3 doses of your Actimorph and get through the day. If you're having a good day, then you don't need to take it. And if you look at the daily or sort of across the week and then across the 24-hour use of morphine, the Actimorph or Oromorph doses will probably stay the same, but you've taken away the background. So the background actually isn't really helping. All it's doing is increasing your 24-hour dose of morphine, which is what we're trying to get away from. So take it half an hour or 45 minutes before you have your physio, and then your physio, you'll get more out of your physio. If you know you're going to go for a walk or you're going to go to the hospital for an appointment, take some before you go, and that will get you through that appointment. But don't have that constant background that's interfering with your sleep and your relationships and your ability to...
No, I mean, fascinating stuff. So rather than a blindly taking them as prescribed on that bottle, it's much more of a individualised, bespoke, maybe even proactive approach.
Take it to support function.
Yeah, love that. Fantastic, Lucy, thank you. Well, I was expecting CPD, but I mean, that's solid CPD for our primary care colleagues. Fantastic. I mean, final questions. I know 20-minute clinic is always, I feel as though we need to extend it where we can, but final question. I always try and ask our colleagues in the NHS about this, and I'm always intrigued to hear responses. So the NHS is tough at the moment. Yeah, it's a real effort to try and advocate and support our patients in a really difficult scenario that we find ourselves in. But just picture yourself. What's one thing, both of you, I'm keen to hear from both of you, what's one thing you feel as though you'd love to see that the NHS does or could offer that would help support you look after our patients?
More psychologists.
Well, the obvious one is to kind of increase our capacity so that we can support primary care to see more of the complex patients. But actually, I think there's something really simple that we can do as well, which is around, and not just talking about those legacy patients, but talking about kind of patients who are at risk of developing kind of chronic pain conditions, is thinking about the language that we use and just ensuring that health literacy is kind of on all of our agendas, and thinking about, do people really understand what language we're using and what we're saying? The things that are second nature to us, like I understand what the term hypertension means, but you could pull 10 people off the street. They won't know that. They won't understand that. And I think when we start talking about people's pain, especially back pain, and people talk about crumbling spines, bone on bone, that conjures up images which are incredibly frightening. And that's that, again, that emotional aspect that's coming into people's pain, because they imagine what's happening every time they move. So I think just kind of thinking carefully as healthcare professionals about the type of language that we use, and that we ensure that patients understand what we mean by that instead of letting them reach their own conclusions, is probably the simplest, most cost-effective thing that we could do.
We all know that if all 4 of us in the room today had an MRI of our spines, we'd all have widespread acute degenerative change, because we understand what that means. That means we have lived on this earth for a number of years and our back has got little creaky bits, and that's completely normal. But if you are very anxious about your back pain and your doctor says, or you read yourself on your MRI scan, widespread acute degenerative changes, a lot of our patients come in and go, my spine is crumbling, and they're frightened to move. And of course we know that motion is lotion, as our physio colleagues keep telling us, and actually it's all about moving. But these patients are frightened to move, and we've made them frightened to move by using ridiculous language, which we understand and think is quite clear, and they don't. And so, having that explained, that that's completely normal and it's fine. It doesn't mean that if you move wrong, you're going to be paralysed, which is what a lot of our patients think, because it's emotional, isn't it?
You just forget, I think, for a second in clinic by slipping into that technicalities. And I won't excuse it, but you can kind of almost see it. If you're running 20 minutes behind in clinic, it's very easy to slip those words in as a way of almost shortcuts to try and get that patient from awareness of what's gone on from their MRI scan through to a plan.
You've got a couple of minor disc bulges, but they're nothing to worry about. So we know that a couple of minor disc bulges, again, we've all in this room, I'm sure, got at least a couple of minor disc bulges, and it is just normal. If we scan everybody, we're going to see it. Absolutely. And there's very little correlation generally between people people's pain and what is on the MRI scan. So unless they have an acute neurosurgical emergency, the MRI scan of the back is almost pointless, and I would say sometimes actually causes more problems than it solves, because then it's written down, well, I've got disc bulges. And so then that becomes sort of part of the person's sort of reason for being, and I can't move because I've got disc bulges. And actually what their disc bulges need is more movement, a stronger core, more movement, and less anxiety, and actually that will make their pain go away. So we have a responsibility with our language.
I mean, normally I expect people to go present a suitcase full of money in, and then we can fix everything. But actually, this is a beauty I love about the NHS, that we will look for the solutions, the ideas that may not require almost money behind it. We'd love it, honestly. More resources would be fantastic. Yeah. But these small niche things can have a real fascinating impact with our patients. I'm really sorry to say, Ingrid, Lucy, it's been fantastic, really, really interesting hearing. I've taken some really interesting points away from my own practice. I really hope our listeners do so as well. Again, just thank you so much. Really appreciate your support. Really difficult, challenging aspects to this, and I think your support is very much appreciated.
Thank you.
Thank you. Just one final note.
Yeah.
The Persistent Physical Symptom Service is in our 10th year, so we're having some 10-year birthday celebrations later on. We've hired the Melissa bus, so I believe we're going to be doing a little bit of a roadshow going from kind of West Cumbria. We're going to end up in Carlisle at some point, and it's just kind of really just to say that there will be kind of events advertised nearer the time.
Fantastic, guys. Really, really good. Very, very happy to support, and if we can do anything to kind of highlight that, absolutely, with our listenership. Thank you so much.
Thank you.